Hello everybody, I am Dr. Rehan Sabir. I am a general and anorectal surgeon at Maven Medical Center, which is a daycare surgical facility in Hyderabad. Today we are going to talk on the very common problem of the anorectum. That's a hemorrhoids, anal fissures and anal fistulas. Now with the day in and day out we see these patients, and it forms a total of 30% of the surgical practice for every surgeon. And we have at Maven Medical Center has specialized in these subspecialty of anorectum, and we have been doing the practice of anorectal surgery with open techniques as well as using other methods with newer methods and different modalities including the lasers since more than a decade. So today I will be very briefing about these three entities, the three different problems which are very commonly encountered day to day among our individuals, and we have been seeing both the genders who are affected by these as well as the younger age group as well as the elderly people. Now we'll start with what exactly is this anorectal disorders. Usually the common man thinks everything is piles. So for any problem like bleeding from the anus or pain while passing stools, they say I have got a problem of piles. Unless and until it has been examined by the consultant, by the surgeon to differentiate whether it is a fissure or the hemorrhoids or piles or anal fistula, because the treatment is different for all the three of them. Briefly, I will just tell you, hemorrhoids are the vascular cushions that physiologically and normally present in each one of us, and due to the straining for defecation or because the patient has been constipated, they put a lot of pressure, intra-abdominal pressure, to evacuate their bowels. And those individuals who have been into the work where it makes them to sit for a long time, there is a prolonged sitting, this causes these cushions to slide down and they forms the piles. And there are four different degrees of piles: grade 1, 2, 3, 4. Grade 1 is the piles which remains inside and it bleeds. Grade 2, it prolapses outside and it goes back instantly on its own. Grade 3, these are the piles which comes out but doesn't go back on its own. It has to be manually pushed from outside. And grade 4 piles, which is the last degree, in which the size of the pile is so big that it cannot be pushed back even after manual reduction. And the complication of the piles, if not been treated, that they form the thrombosis. There is a blood clot inside, which is a very painful condition for the patients, and sometimes they even get infected and forms the pus. So before this happens, we advise these patients who have been suffering from bleeding from the anus to come at the earliest and see the anorectal surgeon instead of going here and there, and they waste a lot of their precious time, and by the time they come to the surgeon it's already grade 4, for which we have to go for a surgical procedure. If they come at the early stages, we have different other modalities where the surgery can be avoided, and with the minimal invasive techniques we can manage their piles. Second group is those individuals who come to us with anal fissures. Usually the fissures patient will present with a lot of pain instead of bleeding. They do also have a bleeding part, but they're prominent and more predominant, the complaint is painful condition. They have a lot of pain at the anals while they defecate, while they pass stool, and after that the pain prolongs for 3 to 4 hours, 6 hours, 7 hours. Sometimes if the condition is so acute, they find even difficult to sit on the flat surface, and just by the sitting posture we can make out this patient is suffering from an acute fissure. The fissure, they don't have a degrees, but they have, because of the duration, we have an anal acute fissure and chronic fissure. Now over a period of time, these patients, they take some medicines, herbal medicine here and there, and they get the symptomatic relief, but the fissure itself is not being cured. So they keep on coming this, they keep on getting this acute conditions again and again, and they form a chronicity of this condition. When these patients are being seen by the surgeon, we find that there is a fissure, there is a cut of around 1 to 1.5 centimeter at the anodum, and they have an associated other disfigurement of that area. They will have a sentinel pile or a skin tag, we call on the common man, and they will have a hypertrophy and endopepidae inside. Sometimes this fissure has also been seen as infected and form an abscess, the intersphincteric abscess. So with all these difficulties and complications of the fissure, when they come to us, we don't have any other option other than going ahead with the surgical procedure, and we do a proper surgery for that. Normally, when these patients will come to us, we advise them to advise them to take a conservative line of management, because 70% of the fissures they heal just by conservative line of proper management. and change in their food habits and lifestyle modifications. But if the patient present to us in a chronic condition, then we don't have any other option than going for a surgical procedure. We call it as a fissurectomy or a lateral internal sphincterotomy, because the sphincters which are there, which controls our defecations and the flatus, because of this fissure, they go for a spasm, and they increases the rectal pressure. So when the pressure increases, that decreases the blood supply to the area, and by which these fissures occur and this wound occurs. So when we decrease the rectal pressure, the pressure over the blood goes away, and the wound healing start to take place. So we have different modalities, and we have a chemical sphincterotomy by which we use some medicines or some ointment. We can use it topically, which increases the vascularity of that area, and it heals the fissure very fast. And if the patient has come in the last stage, or you can see a lot of chronicity is there with a lot of disfigurement and infection over that area, then we advise the patient to go for a proper surgery by which we remove the whole fissure, we remove the skin tag, we remove the hypertrophied anal papillae, and we also do a lateral internal sphincterotomy. So to break this spasm, this tightness of the internal sphincter, we give a 1 centimeter cut into the sphincters under vision. By giving the cut, the whole sphincters will become relaxed. Once the sphincter gets relaxed, the pain will decrease, the fissure will begins to heal. Now, usually it takes around 4 to 6 weeks for the fissures to heal when being given proper treatment. And if we just neglect it, it forms like an abscess, an infection. Normally we encounter the internal sphincteric abscess, for which we have to do a little bit extended procedure of fistulotomy or fistulectomy along with that. Now coming to the very common, the third variety of this endorectal disorders is the anal fistulas, which are nowadays very commonly seen. It is an infectious disease by which we see a lot of infection, the pus coming out, pouring out from around the anus, sometimes from the anus. So these type of patients, they present to us with external opening is there, by which they will be passing pus, blood and seroma, and it's a very painful condition. We have seen patients coming with the history of the anal fistula more than a decade also. They try here and there the herbal treatments and all, and they go to the quacks and they get the treatment done, which is not very much scientific. By the time they come to us, there is a lot of fibrosis, a lot of complication has already taken place. So the job becomes very challenging even for the surgeon to get the patient rid of this fistula. So, but anyway, we have different modalities, different treatments we have to treat these fistulas. Whenever the patient will come with a history of fistula, when we examine, we always advise this patient to undergo an MRI of the pelvis, the fistulogram, by which we can differentiate the different varieties of fistula. Very commonly are intersphincteric fistula, which is seen between the two sphincters, transsphincteric fistula, which pierces both the sphincters and come inside the anus, communicates inside the anus, and they have been found in different levels, low level, mid level and high level. So these are all the things which we will be able to make it out only on an MRI. So when the MRI report comes to us, then we design the whole procedure, the surgical procedure, and we explain the patient what are the risks that has been involved. Usually the fistula surgery is very safe for the patient. We have been doing this since more than a decade, but the patient gets admitted in the morning and we do the surgery, and the patient can be discharged in the same evening after 4 to 5 hours of observation. And normally these patients will not have the recurrence unless and until they do change their lifestyle. Basically the fistulas are the cryptogranular infections. So we ask the patient to increase their immunity to maintain the hygiene of the anal area so that they should not have a recurrence of this fistula diseases. We also have a laser diode laser which we use for most of the fistula cases. Depending upon the patient's presentation, the findings there, we decide for the patient what is best for the patient. So if you know among your friend circle or anybody in your society who has been suffering from piles or anal fissures or anal fistulas, do recommend them to come and visit us. We have a female surgeon for our female patients, and we have a team of surgeons here. We have a very good team of anesthetists and radiologists. So as a team, we will approach the patient and give the best services at their disposal. Thank you so much.